Welcome to the Kimberly Elayyne Show. Today's episode is one that I've been very looking forward to. I'm joined by Alec Bradbury, board-certified family nurse practitioner, who has dedicated his career to working with underserved communities, including people who are unhoused and those living with complex chronic pain and long-term illness. What I deeply appreciate about his work is that he doesn't just talk about medicine, he talks about people. He focuses on helping both patients and providers better understand the realities of chronic pain, and he places real emphasis on validation, trust, and meaningful communication in care. Alec believes that many of the biggest failures in healthcare don't come from a lack of effort, but from gaps in communication, moments where people aren't heard, believed, or treated as whole human beings. His approach centers on caring for the whole person, not just a list of symptoms, especially when supporting those with complex chronic conditions. This conversation is thoughtful, honest, and deeply needed for our community, and I'm grateful to have you here. I think so many of us are going to feel seen in this discussion. So please tell us a little bit more about yourself and what made you want to become a nurse practitioner.
Well, thank you, Kimberly, for the super kind introduction. A little bit about myself and why I wanted to become a nurse practitioner. To start things off, I kind of always knew I wanted to be in the healthcare field. I once accompanied one of my friends who was battling cancer at the time to one of his physical therapy appointments. And I just loved what his care team was doing for him, the impact that it had on him. And so initially kind of started into the physical therapy realm. But then as I went through my career and as I went through university, I realized that I want to be a little bit more involved in my patients' care, kind of be at the intersection of where some of these decisions were happening. And so I kind of pursued my options. I loved what the nursing field had to offer. I loved the holistic approach to patient care. And I think that has played a big role in my message and my development as a provider. And so this beautiful kind of intersection of being at the forefront of the patient care while being able to care for them holistically is ultimately what drew me to the nursing field and becoming a nurse practitioner.
Oh, that's beautiful. What made you focus on chronic pain and complex illness specifically?
So funny enough, coming out of NP school, right, I was treating a lot of chronic pain and I hated it. To be completely honest, chronic pain was like maybe the last thing that I wanted to treat. Like I had patients coming in and I just felt like I couldn't help them to the degree that I wanted to. They weren't really getting better. I'm giving them these medications, but I can't give them for too long. Or if they are longer acting, they all come with side effects. I'm sending them to all these specialists and the care is fragmented. They're it's 3 months out before their appointment. They go to that provider, then they go out to their other provider. We're not talking at all. We being myself with the other providers. It's very fragmented. And, some patients got a little bit better, but a lot of the time they were just really managing the pain and oftentimes not very effectively. So I said, look, if I'm going to be in this field for a long period of time, I can't live like this. My patients can't live like this. They deserve better. So I did a very deep dive into chronic pain, specifically chronic illness as well, because it's kind of hard to decouple those two. And I felt like my understanding exploded in terms of the factors that contribute to chronic pain, as well as the things that we can do to help manage it and sometimes even cure it, right? Or at least lead a much better quality of life at the end of the day than what I felt like I was necessarily trained to do, what a lot of my colleagues were trained to do, and what my patients were experiencing. And so once I felt like I had this understanding, right, I was like, hey, I found it to be extremely fascinating, but I said, this is an area that I can make a real difference in, right, is getting this understanding out to the world a little bit more and a little bit better. Right. To providers, right? I'm not the only provider that feels this way, I'm sure. Right. And ultimately what drew me into the chronic pain and chronic illness space was there is a massive need and a massive gap in what we understand, I feel, as providers, at least many of us, and as well as kind of the care that these patients are getting. Right. And there's just so much that's left to be desired. And so ultimately I was like, I can't just sit on this information or just, really kind of be a generalist. I need to get into these spaces a little bit more. And so ultimately that's what led me. So initially I didn't know what to do with it. And I was like, I can leave this space. I just can't.
You saw a need and you saw that even you're honest about what you felt like at first, but how do you feel now after actually being in it for however long you've been in it for? Do you feel like you really have saw the need?
It is Yeah, absolutely. It is a beautiful community, a hard fighting community. I think when I hear, these terms being thrown around of like chronic pain warriors, right? I truly believe that the people in this space really are warriors and they are advocates and some of the most beautiful people that I've had the opportunity to interact with, whether that be virtually or in person. And they're a fiery group too. And I love that. I love constructive feedback and criticism. And so it's great. I feel like I'm learning and I'm progressing in the space as well. And so coming into it with a lot of humility and curiosity, right? There's all the stuff that I'm learning and my experience. But as we know with chronic pain and illness, it's extremely complex and highly individualized. And so learning from community has been awesome. So I love it. I love it.
Okay, I got some questions to get into with you. So,
Let's do it.
what do you think most people, including healthcare providers, misunderstand about chronic pain?
I think most people miss the fact that chronic pain is a condition or disease in its own right? We have this misconception that we experience pain. And if the pain, we have an injury, for example, and if the pain persists, it means that injury has persisted. There is something wrong in our bodies fundamentally. And so we got to go and look at our bodies and we got to look for things to fix, right? It's almost like a car, right? The check engine light comes on, one of those lights come on, right? And now we got to go under the hood and we got to fix some kind of part. But what we don't realize is chronic pain actually ends up becoming more of a disease in its own right? It becomes less of a symptom and more of the condition itself. And I can get into the nuts and bolts of it, but really it starts to get ingrained in our nervous system. Our brain starts to change. Our nervous system starts to become more sensitized. And that's not to say that injury and peripheral processes, right? So not necessarily in our central nervous system or in our brain, but peripheral processes. That's not to say that those don't still exist, right? Those absolutely do in many cases, but we tend to treat just the body or the part or the place where the injury was. And we tend to kind of neglect the complex biopsychosocial factors that play into chronic pain.
How is chronic pain different from acute pain, and why does that distinction matter so much for patients?
Yeah, it's a great question. I think this is one where I wish we had more training on this personally. Coming up, I think we would really benefit as a society from learning more about this. So I'm glad that this is a question. And I touched on it a little bit, right? So acute pain is this signal that something's wrong in response to tissue damage or injury, right? And generally will heal within the expected period time. So usually in the first 3 to 6 months. Whereas chronic pain is pain that has persisted past the point of tissue healing, roughly beyond that 3 to 6 month window. And so when we really dive into it, like acute pain is often registered by the nociceptors in our body. So these are nerves that are in our skin, they're in our muscle tissue, they're in our organs, right? That detect these pain and inflammation signals and they send a signal over to our spinal cord. It goes up to our brain. And then in our brain, it gets registered as pain, right? Whereas chronic pain, when the pain has persisted for longer than the healing period, is really when our nervous system and periphery, right? So the nerves kind of in the peripheral areas of our body become a little bit more sensitized to the pain through real physiologic processes like microglial activation and neuroinflammation. We can get super technical here, but this is where I mean that it's less of this kind of protective signal and becomes more of a condition in its own right. And I think the classic analogy is the smoke alarm analogy, right? Acute pain is usually the functioning smoke alarm, right? You got smoke, so then the smoke alarm goes off, right? And then in the chronic pain conditions, the smoke alarm might be going off, but there might not be smoke. Sometimes there is smoke, but a lot of times there's not. And so why this matters to patients is this really impacts how we approach the pain as well as how the patient approaches the pain and how they live their life, right? Because when you have an acute injury, the smoke alarm's going off, you got to call the firemen, right? Let's call the firemen, let's put out the fire. But if we can understand what areas of our pain are, hey, this is actually injury happening, and this is just my body interpreting safe signals as dangerous, maybe we don't have to call the firemen every single time. Maybe it's okay. Maybe I just hurt, but there's no harm being done. This like balance between hurt and harm. Maybe I can actually go through with is kind of, and again, there are levels to chronic pain, right? If you're at a 10 out of 10 pain, I'm not saying, oh, there's no injury being done. Let me go about my day. That's not going to happen. But lower level of pain, maybe I can go out and still golf or play tennis and participate in the things I love rather than being like, oh no, I can't do anything. I need to go see the doctor. Right. And then it impacts how we manage the pain too. Generally, at first, maybe we're giving some anti-inflammatories, right? Some ibuprofen or naproxen, right? And as the pain becomes chronic, like I said, it's kind of transitioned a little bit more to our nervous system. So maybe there are medications that we can take that target more of the nervous system, right? Like the naltrexones of the world, the duloxetines of the world. I won't get into the nitty gritty of that. Or maybe there are even therapies, like in the case of nociplastic pain, where again, it's become more of a condition of our nervous system. There are certain therapies like pain reprocessing therapy or emotional awareness and expression therapy, these emotion-based cognitive behavioral therapies or emotion-based CBTs that can be effective in some cases too. So it really impacts how we treat the pain. But then again, even the patient's understanding of that can impact how they live their life, which is very important because if every time they get pain, they get anxious or they get put on edge or they think something's wrong, we put our nervous system on high alert. And then that can amplify the pain. And then that can make us feel even more anxious. And then it amplifies the pain even more, right? That the pain fear cycle is what that's. But if we can understand that, okay, it doesn't always mean threat and danger, then we can break that pain fear cycle, right? Which can keep the pain from not getting totally out of hand sometimes and can help us to lead our lives.
A lot of pain patients and chronic illness patients feel that pain medicine has been restricted, since the opioid epidemic. How do you feel about that, or what's your stance on that?
Yeah. So I totally hear them. And I think that the pendulum has swung a little bit too far in that realm. I believe that controlled pain medications are kind of gatekept a little bit too much out of fear of misuse and diversion and addiction, right? And we end up falling short of treating the pain itself. And we know that especially in acute pain and chronic pain, where we get a lot of chronic pain is actually from untreated acute pain. I talked about how this pain can be encoded in our nervous system. And when that threat to our nervous system is so strong, when we're in that 8 out of 10, 9 out of 10, 10 out of 10 pain, and we're met with suboptimal, pain medication, we're stuck in that state. Our nervous system is going to encode that as an absolute threat, right? And be on high alert for that. And that is a great predictor for chronic pain. So on the front of acute pain, we absolutely need to treat the acute pain. And then on the front of chronic pain, right? And this is a hot topic today, but I think we need to meet the patient where they are. And we often run into issues of, hey, maybe I can treat it without controlled pain medications. We've exhausted all of our options. None of these work. And, I think this other thing might be able to work in the future. It's going to take a while. And we just end up, and the patient is like, hey, I've tried all these medications. Maybe I've even tried these opioids or pain medications and they've worked for me. And we still just kind of sweep that under the rug and ignore it. Right. And we try to go every other route, even routes that they've already gone, and they exist in pain. And it's unfortunate, one, for the quality of life of those patients, right? Their whole quality of life deteriorates. They're probably more at risk for going out and seeking street pain medications, which might be cut with something else, might put their health at greater risk, right? And it oftentimes turns the patients off from the very therapies that we want them to do, right? That we think might be beneficial for them, right? So if a patient, I know there's a big divide, right? And especially when we start talking about cognitive behavioral therapy or pain reprocessing therapy or something like that, that may be beneficial to a patient, right? You think, are you saying the pain is all in my head, right? It may actually be beneficial for processing these pain signals, but when you're in 10 out of 10 pain, it's not going to do anything, right? When you're in significant, you can't participate in the practices that they want you to do. And then when you try to throw that on as the thing that's going to help them and you kind of just neglect treating the pain as it is right now, they're going to kind of grow to not want to do those therapies. And I don't blame them. And so there's this whole snowballing effect of we're doing everything we can to not prescribe these other medications. And they do come with real risks. That's true. But we have to meet the patients where they are rather than trying to project what we hope will work for them. And so it's tricky. It can get tricky sometimes. But I definitely am on the side of the pendulum has swung too far from kind of de-prescribing these medications. in the instances of patients who have been on it for a long period of time and their quality of life is great, in stripping them of those, yeah, I'm not for that whatsoever. I've seen plenty of patients who have been controlled on it a long time and their quality of life is totally good. And why would we take that away from them and then decrease their quality of life? So yeah, it's a hot topic today. It's a hot topic today.
Appreciate you saying something. As a chronic pain patient, I always am under the belief that, pain management is suicide prevention, whether that be pain medicine and things like that. A lot of people have ended their lives because their pain medicine is just ripped from them. So it's just,
Hmm.
it's an important topic to talk about. So thank you for touching on that.
I agree.
There are communication gaps in healthcare. What do you see going wrong most often between patients and providers?
I love this question. And this is kind of the basis of much of my message, but it really boils down to patients and providers aren't coming to an understanding, right? Oftentimes patients and providers, they are sitting on opposite ends of the table. I mean, quite literally opposite ends of the table or of the laptop or whatever it might be. They're never coming to an understanding. The patients are bringing their concerns. Maybe the providers ask some questions. And then after a while, the provider is going to, go down their little decision tree, spit out a diagnosis, spit out a treatment plan, right? Without ever making the patient feel understood, right? And this just boils down to basic communication. This isn't even patient and providers. This is two people trying to agree on anything, right? Trying to come to an understanding. I mean, these are two people trying to come to an understanding, right? And so if one person doesn't feel understood, they're not going to want to hear much of what the other person has to say. So it really boils down to this statement of seek to make the other person feel understood and then seek to be understood, right? And I want to shine a light on this idea of feeling understood, right? Because you might say, oh, seek to understand, then to be understood. If I'm a provider and I'm typing away on my laptop, right? And I'm listening and I understand where they're coming from. If I have this stone cold, document face, they don't know that I understand them. They're not going to want to feel like they want to collaborate with them, right? So the basic thing that we can do is to show a little bit of empathy, right? It really boils down to that. And that just might be simple as I believe you. It's really that simple. And that can bring us to the same side of the table. Now we are on the same side of the table looking at the problem together, right? Which are these symptoms that you're having, right? The way that it's impacting your life. And so I feel like if we could just come to an understanding better, and that's mainly on the part of the providers. Yes, we're stressed, we're rushed, we're trying to take in all of this information, we're trying to make decisions, and it can be difficult. But if we pause for a moment and recognize that if I don't make this person feel understood, everything that I'm doing, all the mental gymnastics I'm doing for diagnosis and treatment and whatnot, might be for naught. And we know from extensive research that when a patient feels heard and understood and they're getting personalized care, that their follow through on that treatment plan is better. So it's not just some extra, here's something to make you feel good. It is quite literally part of their treatment and part of their recovery. And so I think if we can get to the same side of the table, if we can get to an understanding before proceeding, right? And I'll say the provider never fully understand what that patient is going through, right? Because they haven't lived that experience, but you can at least express empathy and make them feel understood, right? And so I think that's where a lot of communication breaks down. I really do. I think it's just we're not coming to an understanding.
How do patients advocate for themselves, especially when they feel intimidated, exhausted, or not believed? And what can they do?
Man, this is a very important question. And I like to start from before the appointment, right? What can we do going into an appointment to help advocate for ourselves a little bit better? Right. And one of the things is just to make a short list of our priorities. What are the main points that we want to hit on? The main 1 to 3 points that we want to hit on in this 10, 15, maybe 30-minute appointment if we're lucky. What are those main things that we want to hit on? And number two, and this is one of the most important things I think, is having a partner that you trust at that appointment. It can be your romantic partner, it can be a family member, it can be a friend, someone that you trust and you actually want there advocating for you, right? Because it can all go awry if this person isn't someone that you really want being there, right? But when you have a partner there, they can help remember things for you. Living with chronic pain, living with chronic illness, right, can lead to a lot of brain fog. Now we're in this highly emotional, kind of stressful situation. I'm trying to remember everything that you wanted to say and go over, and maybe the provider is making you feel a certain way, right? And so the partner can help to remind you of the things that you want to bring up, so we stay on track with those priorities. And then they know your tells. And what I mean by that is if you start to feel overwhelmed, maybe start to shut down in this emotional interaction, you're not sure how to respond, you're battling those emotions, they can also see that and interject and jump in on your behalf, which is important. And then a lot of patients will tell me that their providers take them more seriously when they have their partner in the room. And I think this is particularly true for our female patients, right? They feel dismissed and a lot of their symptoms feel dismissed, but when they have her there to really advocate for them and to really give their account or even just be there and sit in the room, they find that the providers take their concerns more seriously as well. And it shouldn't be that way. It really shouldn't, but it often is. And so I think off the bat, those two things, right? Okay, now we're in the appointment. Maybe we're feeling a little bit overwhelmed. First and foremost, trying to come from a place of curiosity is super important, right? This is just basic kind of communication that we're not really taught. But when things start to get charged and we start to become maybe angry or frustrated or upset, right? Oftentimes, what will happen is people will end up getting backed into a corner. They'll start to get more defensive than collaborative. So if we can stay a little bit curious, even if we're feeling a little bit, some type of way inside, rightfully so, if we can come more from a place of curiosity, then it opens up a dialogue, right? Why you don't think the symptom's important? Like, want it to come from a place that sounds genuinely curious. Like, hey, can you help me understand why you don't think this symptom's important, right? And that opens up a dialogue rather than backing the provider into a corner where things can quickly kind of escalate, right? Using I statements is another one, right? I feel emotion when situation because reason, right? And that's just the general framework. But I feel worried when my symptoms are dismissed because I can tell when something's not right with my body, right? And now, so we're able to name the emotion without maybe expressing it in its fullest, in its entirety, right? Because from communication can back the provider into a corner. We're not really trained for highly emotional interactions. I'd say I am. I feel like the nursing realm does a really good job of. Not every provider really is, and so, but you're able to name the emotion, right? And it doesn't always have to end in a question. Let it be that statement. Let that really hit the provider, and let there be some silence. Might be some awkward silence while they think about that and respond. And I think that's really important. Now, there is a time to be direct though, right? Where you say, I think we should look at other options. I would like to pursue looking into this symptom more. I would like to pursue, you know, whatever it might be. That can be really important as well. Now, there does come a time where, oh, and one last thing too. A lot of times providers skip on the shared decision making. I think shared decision making is fantastic. The patient is in their lived experience. I'm the expert in, or supposedly, supposed to be the expert in this condition. Sometimes, honestly, the patients are more of the expert in the condition, to be completely honest. There should be shared decision making. And sometimes providers will just spit out a diagnosis, they'll spit out a treatment plan. And if that happens, right, I think a really good thing you can say is, thank you for coming up with a treatment plan that you think is going to work for me. I would like to explore the totality of our options, right? If possible. And that way, again, you're not just saying that I want other options, right? You thank them for genuinely trying to come up with something they think might work for you, even if you think it's complete BS. But then you can kind of force in making, right? You can even ask, like, do you have questions about my preferences, right? And have them kind of put them on the spot to talk about that. I think that's important as well. Now, there does come a time where they just don't get it. They don't get you. They're making you feel worse. Conditions getting worse as a result. You're fighting and clawing and scrapping to feel heard, even just for the to come out the same as you went in. A lot of patients will come out worse, right? In those instances, you really shouldn't have to work so hard. And so finding another provider, getting a second opinion, maybe even filing a is would be warranted. And remember, and this can be very empowering during the appointment as well. Your provider works for you. I know there's this power dynamic of you under the provider, but the provider works for you. If they're not doing it for you, they're making you feel worse, then you can fire them.
Wow. I think a lot of people fight, they're in the fight or flight mode. I know if I have a provider that's like, well, your symptoms are this and this and telling me what I feel like I either fawn and then I go and cry. And then I think, like you said, like speak up for yourself and bring a partner, which reminds me, I have a doctor who recently retired. She's a neuroimmunologist. gastroenterologist. And she's like, even with my degree, if I go in and I bring a partner, I'm treated better and people take me more seriously. So you actually have a point that you made. And so even if doctors are feeling like that, patients must be as well.
100%. I love that.
Yeah. So there are parts of chronic pain that people don't talk about. Grief, anger, identity loss, feeling like a burden is a huge one. Why do you think these topics are taboo in medicine?
Yeah. Yeah. It's a great question. And I touched on it in the last one too. I think first and foremost, providers aren't trained to handle these emotional situations, right? We're kind of taught, especially in the medical model, to kind of see the symptoms. Okay, now we treat with this, right? Oh, if the patient is experiencing grief or they're experiencing anxiety or depression, right? What's the next step, right? On the exam, all right, we're going to refer to therapy, CBT, right? Or if it's severe enough, maybe an antidepressant prescription if you're even comfortable doing that, or refer to a psychiatrist. There isn't much training or questions in how to respond with empathy and how to deal with grief. And I think there's also a lack of lived experience, right? So we don't have the training in this area, but the lived experience of this identity loss and this grief. And we might have a shared experience of grieving the loss of a life, right? That is a shared human experience of losing someone close to us that we love. That might be a way that provider can relate, but have they lived the experience of grieving the life that they thought they would live at one point, right? Because their chronic pain or chronic illness has caused this patient, this person, right, to have to accept and adopt a completely different life. And that's not something that they've lived. So we're not trained for it, right? We don't have, I think, again, in the nursing field, we're better trained for it than has been my experience, but I've come across a lot of NPs who are not very empathetic in this scenario, right? So we're not trained for it very well. We don't really have the lived experience to relate to it. And so when you have this, provider that's not empathetic, and we have the patient who's suffering here, and we have this complete disconnect of where we are, and just leads to this kind of awkward gap. And I guess, okay, I'll write you a referral to therapy and we'll see you later, right? We don't really have a lot of time too. So I think it's really a combination of those things, and something that we really must be better about in the society. And again, that gap also kind of comes down to, we're so used to treating the body and not really the mind. That belongs, we have separation, which in chronic pain, I think does the patient a lot more harm than good. We need to be better about educating about both, because at the end of the day, we're treating the whole person in front of us and not just their body.
Good answer. I like that. So I have a couple questions left for you. Somebody in the community asked the thoughts on intersection of childhood trauma slash CPTSD, chronic pain, ADHD, and complications. Says my experience seems to show it is kind of perfect laboratory settings for dissociative issues. The misery aspect of inescapable pain's threat to the nervous system seems to scramble the nervous system. What are your thoughts?
Yeah, I think you summed it up beautifully, right? All of these conditions that you mentioned kind of share common pathways in how the nervous system processes threat, stress, and pain, right? And so, for example, in someone who's experienced childhood trauma, especially repeatedly, right, our brain and our nervous system will fundamentally change. And this can affect how we develop and respond to threats, right? So, for example, if we have a threat come in, even if it's not really threatening, right? If we're just going about our daily life, our body will respond to these external stimuli, sometimes completely threateningly, right? And so it changes how our body relates to threats, right? Amplifies them a lot more, right? It also impacts our experience and perception of pain signals as well. I can definitely amplify those too. It also impacts our ability to regulate our emotions and stress too, and as well as our ability to kind of relate to ourselves and our surroundings. And so I love that you mentioned dissociation, because I think that's so huge here, right? Dissociation, meaning like feeling numb, feeling like you're not fully there, like you're not yourself and can't really relate to your surroundings, even to the extreme of being outside of your body, looking at yourself, right? And lapses in memory and whatnot. And really, that's just your nervous system trying to protect yourself, right? When you mix something like childhood trauma, PTSD, in chronic pain, your nervous system is constantly trying to manage inescapable threats, right? And I think that's what it boils down to. And so what better way to escape and manage inescapable threats than escaping, right? Associating, then numbing yourself and being outside of yourself and not actually being fully present in your body. It really does kind of lay the foundation for this dissociation. So all these shared neural pathways really do impact how we process stress, threat, and pain. And they all are very intricately interconnected.
Wow. I always wondered, like, because I have, chronic pain and I have dissociative identity disorder. And I always wonder if the two are hand in hand. So if anybody in the community has those two, I'd love to hear from them. And it's an interesting topic to talk about. Absolutely.
It is. It's a fascinating question. Could probably be a whole podcast series in and
I
of
know.
itself that would go beyond my training.
Join me again, Alec, for the next one.
I will. I'll
Um,
have to read up a little bit.
um, we just have a couple more questions left. That's awesome.
Hmm.
Is chronic pain ever all in someone's head? And what does that phrase actually get wrong? I know you touched on this earlier, but I'd love to hear it again.
Short answer, no. Chronic pain is never all in someone's head, right? And what that misses is that it's almost saying that the pain isn't real, that the pain is fake somehow, right? But pain is pain. It's all processed in the brain, right? So sometimes you hear people say, "Oh, it is literally in your head," but not in the way that it's being phrased, right? It's not how some providers think, "Oh, it's all in your head." Pain is pain, whatever the source of it is. That pain is real to that person, and they are experiencing it. And we need to get to the root cause of it or treat it at the very least, right? Or we should treat it concurrently. So it's never fake. It's never not real. It's never all in somebody's head, right? Pain is pain and the pain is real. I'm going to keep this one kind of short and sweet. It's a wide version of it.
That's to the point. All right.
Yep.
And last two. If someone listening feels invisible or hopeless right now because of their chronic pain, what do you want them to hear?
First and foremost, I want them to hear that they matter and their lives matter and the world is a better place with them in it. That I think above all else, right? Secondly, if they're feeling hopeless, I want them to hear that there is hope out there. If they feel like they're not supported, there are people that are waiting to support them, right? That they're not getting help from their providers or their medical community, that are being gaslit and dismissed. There are providers that are ready to help them, that want to help them, right? They feel like they just, there's no way out. There's nothing that can help them with their pain and help them with their condition. There are so many things that we're learning about pain every single day that even providers don't know at this point, right? There's this lag between when research comes out and gets implemented into practice. There's things coming out every day that's just so exciting. And so I want them to hear that there's hope as well. There's hope for support and there's hope for having a life where you have meaning and where it has quality. And so more than anything, they belong. The world is a better place with them in it. And please don't give up.
Thank you. All right. Now, where can people find you, Alec?
Well, people can find me right now on social media at Alec Brad FNP. Find me on Instagram, TikTok, just launched Twitter. I don't even know, probably still at 0 followers, but just X, whatever. I can find me on those 3 socials, even on Facebook as well, just at Alec Bradbury FNP. Simple as that.
I just want to say thank you so much on behalf of our community. I know there's a lot of medical professionals on social media that tend to make fun of chronic pain patients. You are far from that. You are absolutely wonderful. You're so dedicated to helping patients. And on behalf of the community, thank you so much for sitting down with me today. And thank you for being a voice for us in the community.
Thank you. Thank you so much for the kind words. And thank you for being a voice and providing this platform and elevating voices and asking the questions that the community really wants asked to people coming on your podcast and really giving people like myself a platform to speak as well. And so thank you so much for having me on. It's been an absolute joy.
Thank you, Alex. I hope you have a good day.
You too.